Or is that a sweatshirt?
It's kind of in between.
I like it. It's
All
cool
right.
color.
I think we're live. Let me check. All right. So now I'm going to share to a couple groups. So hang on. All right. I think we're good. I think we're streaming. All right. Welcome everyone to this month's TBI talk with Dr. Perry Maynard from Integrated Brain Centers in Denver, Colorado. Today we're talking about movement disorders. It's something I have been seeing in the group a lot recently. And so I just kind of want to talk about this topic and what are some of the reasons that people can get movement disorders, how they could present themselves, and we'll just kind of go from there. So welcome, Dr. Perry.
Yeah, thank you so much for having me, Amy. And I think this is a great topic because it's something that is, we see quite a bit after concussions. There can be lots of reasons for movement disorders, but of course, head injuries or concussions can definitely be big triggers. And kind of like the name sounds, movement disorders in essence are just a disordered movement, right? So movement disorders are usually classified into really one of two categories, to keep it simple: hyperkinetic movement disorders or hypokinetic movement disorders. And kind of like that sounds, hyper, there's too much movement, and hypo, there's not enough movement, right? And that's classically how things can be kind of characterized. And kind of your big examples of like a hypokinetic movement disorder are things like Parkinson's, right? Although Parkinson's patients have tremors and what you could argue appears to be excess movement, really they have a lack of movement, right? They're very slow. They're very rigid.
Right.
Their blinks are slow, right? So technically it's a hypokinetic, and we can talk about what that means later, besides just slowness of movement, versus hyper, where there's too much movement, right? So this could be something like what's called choreiform movements, and that may be foreign with people. It's where people make maybe snake-like movements, or a condition that's called like Hemi Belismus, which is a very, something you learn about in school and things like that, where people may get spontaneous movements or jerks, right? And these movements can be in your hands, your arms, your head, your neck, right? They can really be in anywhere where there's muscles controlling movement. So really it's just disordered movement. So there's either not enough movement when you're trying to move, or trouble in initiating movement, or there's too much movement. Or when you try to do a simple task, all of a sudden, maybe there's movement elsewhere in the body. So really that's what simply a movement disorder is.
Mm-hmm. And, I've seen so many different movement disorders amongst survivors that I've met. I don't believe I had any sort of movement disorder that I'm aware of. But like, I have a good friend, she, like, her whole body just kind of shakes sometimes. Well, most of the time. I know other people who just randomly have like twitches or jerks. I maybe did have a little bit of that, like really mild. I might have had some of those twitches. But I have friends who have big twitches. And then I've seen people that, like, when they walk, their legs do crazy things. Like I seen one gal, when she walked, her foot like kicked out to the side, kicked her in the butt, and then came back down. Like, it was the weirdest thing. Right. So, let's maybe break down like what's causing some of this. Because for a lot of people, they're told that they're just making it up, that it's in their head. Well, it's literally in their head, but it's not how the doctor's meaning it. They're told all the time that, you know, you just must be me. Especially I had a friend, he'd accidentally hit people. And yep. And the doctors were like, oh, this is psychological.
Yeah.
So let's jump into that a little bit, like, because I'm sure there's someone watching who has had a similar experience.
Yeah, definitely. So if we look at movement disorders and kind of talk about where they appear, where they seem to come from, right? So there's a few different areas, but mainly kind of two areas we're going to talk about. And the first one is going to be a part of the brain called the basal ganglia. Some people may be familiar with that, some people may not be, right? And this is classically what's studied as where a lot of movement disorders come from, the basal ganglia, but also different parts of the brainstem, right? So the basal ganglia, if we think about it, is, you know, it's taught in a certain light, and it's kind of like we're always evolving, trying to figure out, well, what does it really do, right? So we have a bunch of theories and hypotheses, but really you can think of it as your master kind of computer system that is kind of filtering out all this information. So we know that so many different circuits in the brain fire into or funnel through this basal ganglia, right? And within that basal ganglia, you have a ton of different nuclei, or what you can think of as a bunch of different computer processors changing the dials to decide what information is relevant, what's not relevant, to achieve whatever the goal may be. So if my goal is to grab my phone, my frontal lobe talks to my basal ganglia and says, hey, I want to grab this phone. And the basal ganglia says, okay, let me select out of the filing cabinet what is going to be the appropriate movement strategy to choose. Frontal lobe says, great. And if there's an issue somewhere along that pathway, then maybe the wrong selection is chosen. Or what can happen sometimes is that the basal ganglia, how it works is you have an input, and then a bunch of crap happens in the middle, and then you have an output. That output fires to another part of our brain called our thalamus, right? And our thalamus feeds back to excite our cortex. And so what happens is that basal ganglia has what we think of as like a tonic inhibition of the thalamus. So think of everything as a car in RPMs. So say healthy RPMs of this thalamus is 1,000 RPMs. It's not running too high, it's not running too low. And that part of the basal ganglia, what's called the pallidum, is keeping that at that 1,000 RPMs, and they're oscillating. And what happens is in certain conditions, sometimes there's too much output into the thalamus, so it slows it down and it depresses our brain. So once again, things like Parkinson's, decrease activity, or and sometimes there's not enough activity coming into this area. So this guy gets really hyper excitable, and then it feeds back into the brain, and you may get a spontaneous movement because you can't gate it, right? So you have all of these inputs coming in, and then if you're really good at selecting the appropriate behavior, then I reach, I touch my phone, I bring it up, everything's smooth. But what if all of a sudden that doesn't work, and I pick it up and it's jerking because I've chosen the wrong selection, or I have a million different competing patterns that could happen, and I need to quiet down all those competing patterns and choose only one. So maybe I have a pattern that's pulling my arm this way, and I'm like, no, come back here. You know, and so you're getting this competing pattern. So there can be issues in the basal ganglia. So within the basal ganglia, you have all sorts of different nuclei. So there could be damage either from a head injury, from a neurodegenerative condition, from a stroke, right? There could be numerous things. What you see a lot of times with head injuries, or what you see with more like functional movement disorders, in my opinion, is that sometimes the input that the basal ganglia is getting is poor. So the basal ganglia is very context specific. So it's all about context of the situation, because once again, if I'm here and I want to touch the computer screen, that's very different than if I'm here and I want to touch the computer screen. You can see how my arm and my trunk are in two different situations. And my basal ganglia needs to know that that's happening. So if someone gets a whiplash injury and now their neck gives poor context to their basal ganglia, their ability to control their neck may not be great. And now they create a dystonia, right? Where they get abnormal contraction. Or maybe my inner ear, my vision is giving me poor feedback to my basal ganglia, which is giving me the wrong context. So now when I go to move my hand, my basal ganglia thinks I'm somewhere else, right? And this is where I think you're seeing a lot of these functional movement disorders, is that there may or may not be something wrong with the basal ganglia. There very much could be something wrong with it, or that phasic input, or that input that's constantly changing from all these different regions, is wonky. And this is where you'll see, I had a patient yesterday, a dystonia patient, where you find them to be very dynamic, where you find ways to change the input or the context into that basal ganglia with hopes that you create a better output from it, right? So if someone's got a tremor and I do something and that tremor slows down, whatever was done changed the input, it got filtered better, and it made an appropriate output. And so now the tremor slows, versus maybe you do something and then it starts spreading to the whole arm. So I think of it in two ways, is that something can be broken in that master computer processing system, or the information it's getting from another area is inappropriate. And that's what's causing, it's like a game of telephone gone wrong, in essence.
Right.
So I think that's kind of a simple way to think of the basal ganglia that really experts around the world don't fully understand, but that's kind of, to the best of our knowledge, how we understand it works currently.
And so what are some things that you and in functional neurology that you guys can do to, because I have seen some remarkable turnarounds with people who had crazy movement disorders and went through a functional neurology program, and they're doing so much better. So what are some things that you are doing with patients to help them minimize or manage that movement?
Definitely. So I think step one is figuring out, can we find out what might have caused it? So once again, if it's a head injury, then we'll chat about kind of how we look at it that, but you can have autoimmune conditions that can mess with that basal ganglia. You can have things like anemia, blood sugar. So step one is figuring out, are there things on the metabolic side that are insulting the brain that's affecting that basal ganglia? Because the basal ganglia is very sensitive to lack of oxygen, but also like chemical toxicity. So that's kind of one aspect. From a rehab standpoint, like we kind of chat about, is the way I think about it, and I've changed my, thought, and this is, a shout out to some other people in the neuro world who have kind of changed my thought on the way I look at some of these things. But is, like we talked about earlier, is I think it's got a constant output that we may or may not be able to change. But we know that the basal ganglia has thousands of different inputs. And what's interesting is some of the largest inputs into the basal ganglia are different visual circuits, postural circuits, or circuits that control body, and then emotional circuits, right? Or the limbic system. Those three things are extremely powerful things into the basal ganglia, right? This is why a lot of people will say, when I'm anxious, my movement disorder gets like 10 times worse. When I'm chill, I'm much better. So what I look at is saying, what are all the different inputs? So it's really no different than any other patient is saying, okay, understanding all the inputs that go into the basal ganglia, how can we quantify that? So what does balance look like? What does one's ability to track left to right, up and down look like? What does one's ability to control their hand, these different things? Because if we can find, what's their inner ear look like? Because if we can find something wrong in some of those circuits that feed into it, a lot of times by fixing those circuits that have such a huge influence on the basal ganglia, you're changing that input, and all of a sudden you can get a better output. So once again, I have patients where maybe they have, this dystonia, or, I had this patient recently who had a really bad tremor after a car accident. And what we would find out is that when we would do things to modulate her inner ear and give her better awareness of where her neck was, her tremor would almost resolve, right? So, what my thought is, did I necessarily do something to change that basal ganglia? Maybe, maybe not. Probably what I did was I fixed certain circuits, and once those circuits worked better, they fed into that basal ganglia at a different rate, and then it allowed to control the hand. So really, I look at all the connections that we can really quantify and understanding how they feed into the basal ganglia. And then I have different testing to quantify those things. And then we may use specific therapies to fix those different things that filter into that circuit to then hopefully allow that circuit to then better control whatever input that was, if that kind of makes sense. So really it's understanding the inputs into that system and then finding ways to change that input to then give a better output. And we're always looking at outcome measurements, right? So once again, if I am doing something to affect the basal ganglia, I may want to see that it makes their dystonia better, or maybe it makes their ability to alternate tapping their fingers easier, because I know that the ability to turn on and turn off muscles very rapidly, the basal ganglia has to help do. So I'll give you one other example. I had a patient recently who has a really bad vocal and cervical dystonia, right, which has led to stuttering. But one of the things is you'll see this sometimes in movement disorders, is you hit maybe like a biceps reflex and their legs move, or you hit a pec reflex and their whole trunk moves, right? So you're seeing these spilling of movements or this excessive activity. Once again, the basal ganglia needs to use things like dopamine to say, you move, you don't move. So whenever we want to move something, the brain will feed a circuit dopamine. And whenever we want to not move, it will pull away dopamine, right? And the problem is for whatever reason, you get dopamine flooding into these full body maps. So with this patient, hit a reflex, everything spills. What we did with him is we did a ton of things to work on proprioceptive input from the neck, and then things to coordinate eye, inner ear, and neck function, and a few other things. And then we get it to where we'd hit his reflexes and they'd no longer spill, right? So did nothing to the body per se, but changed input feeding into that. And I use these different things as outcome measurements, because we can't always say, do you feel better? If something's working better, then all of these other tests that we have should look better, or that basal ganglia should have better control. And if it's got better control now of my bicep, it may have better control of my thought, because it's the same loops, cognition, emotional state, motor loops, all feed through the same system roughly. So this is where you may see that maybe someone's reflexes get better, their tremor gets better, and their anxiety gets better. Or maybe they're racing. So this guy also had perseverative thoughts. So he would sit and just loop on the same thoughts. And when we would do some of these simple exercises, he'd calm down and he'd stop looping, because you're just affecting that whole circuit.
Yeah. And that's what I was just going to kind of talk about too, is, when you have a movement disorder, it's exhausting because you're using your resources to twitch or to tremor or, whatever that movement is. And when you have a movement disorder, it kicks up your anxiety. Like, it can go either way. And so if you can calm down that movement, you're calming so many other things down, like just, a drastic increase of quality of life by getting rid of these movement disorders.
Well, it's exhausting if you think about it. It's the most inefficient thing possible, that if your brain's all about making things as efficient as possible. So if every time you move your arm, your legs move, you're using up so much excessive energy. And then a lot of times your executive part of your brain is trying to suppress that and be like, don't do that. Don't do that. Then there's the whole social aspect where people are in society and they get embarrassed or ashamed about it because they think they look right. So it can be exhausting in so many different lights. It can be extremely debilitating for a lot of people as well. But I think that, functional neurology definitely with patients, I think has shown a lot of hope when there really is very little hope in traditional arenas, for movement disorders. I mean, I think one of the coolest things in medicine is things like, deep brain stimulation, but there's it's a pretty invasive procedure, right? So I think that's interesting, but I don't think everyone's first thought is that they want to have deep brain stimulation. It was interesting. I was chatting with a colleague of ours, and there's some interesting stuff with things like transcranial magnet stem. So transcranial magnet stimulation is been known to be used for depression and like OCD, things like that. But what's interesting is PTSD, I was always aware that it's usually pretty like superficial, like the depth that it gets is not very deep. So it can't really get down to that basal ganglia. But I was talking to him and he was talking about some new models that supposedly may be able to go deeper, and you may be able to modulate some of those nuclei within the basal ganglia with things like TMS. So there's a lot of things, coming out, and we're learning more and more each day, which is good because it gives people hope, because medications for a majority of movement disorders don't tend to be super effective.
Right. Well, if anyone has any questions, please drop them in the comments below. If you have any questions for Dr. Maynard, and if you're watching the replay, leave a question below. We'll try to monitor those and get answers for you as well. I think movement disorders can be just so debilitating in and of themselves, right? And then you throw everything else with the brain injury on top of it. And I just see so many people struggle with medical doctors telling them, either it's in their head or nothing we can do about it. Some people, probably get put on different meds, like maybe Parkinson meds type of things. And it may or may not give them any relief. But, functional neurology is just the thing with me with functional neurology is you're assessing the entire system and you're getting to the root, to the core of the problem, and non-invasively treating it. And, I'm always surprised at how relatively simple some of the exercises that you have us do are. Like, I say simple because it's something simple, like doing a figure 8. Yeah. But when you're like flared up, doing that figure 8 can be really hard, right? Or even just following your finger. But yeah, over time, like we said, if you can get that movement to calm down, you can get the limbic system to calm down, the anxiety, everything else, like memory problems. I know for me, getting my vision, my balance, dizziness cleared up, that was huge for getting my memory back.
Yeah. Totally. I mean, and that it just goes to show, one, we know how much these circuits all feed in and build together, but also, it's like if your brain had to choose between knowing where you are in the world and keeping you upright versus attending to a work meeting, it's always going to choose you not falling. So it's like your brain is just putting all of its resources towards these things. And once you fix those or improve them, you free up so much more brain energy to do these other things and to be able to enjoy life and, be happy.
Yeah. Well, Dr. Maynard, thank you so much for being here today. It's always a pleasure to chat with you. And, thank you for sharing with everyone in my tribe and my page. And I'll send out the replay link. And again, if you have questions, drop a comment. We'll try and get to those. We'll try to monitor those and get you some answers. But if you have any questions, you can reach out to Dr. Maynard at integratedbraincenters.com. And you can always schedule a free consultation. And I'll also drop the link below. If you're interested in finding a functional neurologist near you, Dr. Perry and Dr. Stedman are happy to chat with you and try and figure out a good game plan for you. So thank you for being here, Perry.
Thank you so much for having me, Amy.